All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, our discussion for diabetes continues. With me, the rock star from endocrinology is Dr. Priya Jaisinghani. She is, as you know already, that she's practicing in New York. Uh, Dr. Jaisinghani, welcome.
Thank you so much, Dr. Bean, and welcome, Cool Beans. It's our third lecture today, and I'm very, very excited and grateful to be here again. So as you know, during our first lecture, we talked about diabetes mellitus and how it referred to a group of common metabolic disorders that share the phenotype of hyperglycemia or high serum glucose. And we discussed, the physical manifestations that can occur when you have diabetes. And then during our second lecture, we reviewed carb metabolism. And now throughout these two lectures, we've mentioned the pancreas and its role in breaking down food and controlling blood sugar. So today, we're going to give the pancreas the importance it deserves and delve into the structure and function. So without further ado, we can get into more information about the pancreas. And so the pancreas is a glandular organ that belongs to both the digestive and the endocrine systems. So where is the pancreas? So the pancreas actually lies parallel to and beneath the stomach. And it's a large compound gland. And a gland is a functional unit of cells that work together to create and release a product, either into a duct or directly to the bloodstream. So we can go to the next slide. And so when we're talking about glands, there are basically two principal types. And the two principal types of glands that exist are exocrine and endocrine glands. So there's a key difference between these two types of glands. So exocrine glands actually secrete substances into a ductal system to an epithelial surface, meaning that it's released onto the surface of the target cell or organ. Now, endocrine glands actually secrete products directly into the bloodstream, so they're ductless. So exocrine secretions form in the pancreas in the acinus or in acinar cells, acini. And they're usually small clusters of cells that originate at glandular ducts. And many organ systems actually utilize exocrine glands to carry out their respective functions, right? So for example, we have the skin. It has sweat glands. The mouth has salivary glands. The breasts have mammary glands. The stomach has glands. And then we have the pancreas that we're talking about. So like I mentioned, the pancreas actually has both endocrine and exocrine functions. So the exocrine pancreas actually assists in food digestion by releasing a secretion that has bicarb, which helps to neutralize the acidic environment created in the stomach, and then also has digestive enzymes. And the endocrine system releases hormones such as insulin and glucagon. So let's take a look at the two major types of tissues that actually contribute to the endocrine and exocrine functions of the pancreas. So that would be, the pancreatic acini and the islets of Langerhans, okay? So when we're talking about the two major types of tissues, the islets of Langerhans actually secrete the insulin and glucagon, and they secrete it directly into the blood. So that's the endocrine function that we spoke about. And the acini actually secrete digestive juices in the duodenum. So that's the exocrine function. So do you remember in lecture 2, we spoke about carb metabolism. So we can go to the next slide. And in lecture 2, we had mentioned, that there was a pancreatic juice that was secreted in response to a food bolus, right? So when we eat food, we have mechanical digestion that starts in the mouth. We had some chemical digestion with the salivary amylase. It went into the esophagus. We had propulsion into the stomach where it met hydrochloric acid, and we still had mechanical breakdown. We went into the small intestine. And then we had this pancreatic juice that was released. And we talked about this pancreatic enzyme, right? That was pancreatic amylase. And we said that pancreatic amylase actually helped to digest our complex carbs, right? So our starches, glycogen, into maltose, into dextrins, into oligosaccharides. Well, this pancreatic juice is actually composed of not only digestive enzymes, but also the sodium bicarb and water. So where are these really coming from? So we can go to the next slide. And here we're going to see, so the pancreatic acini actually secrete, like I said, the pancreatic digestive enzymes. So they have nucleases for nucleic acid, proteases for proteins, lipases that break down to lipids, and then amylases for the carbs, right? And then there's also pancreatic ductal cells. So these are the cells that actually secrete the large volumes of the sodium bicarb solution. Okay, so we have the production of enzymes involved in digestion, plus the production of fluids. Okay, and that, like I said, neutralizes the duodenal chyme to basically an optimal pH range, which will activate the pancreatic enzyme. Okay, so now we've reviewed the pancreas's role in digestion in the small intestine with the production of enzymes and bicarb, and that helps to absorb fats, lipids, and proteins. And the last lecture we had seen that, carbs were broken down from complex carbs to the polysaccharides and disaccharides to simple carbs, monosaccharides, through these enzymes and disaccharidases, and then absorbed into the bloodstream. So now we have the glucose circulating throughout the bloodstream in the body, and it reaches the pancreas. So the pancreatic blood actually circulates to the islets of Langerhans. So we can move to the next slide, and we can talk about our new friend, the islets of Langerhans. Okay, so the islets are actually small islands of cells that produce hormones that regulate blood glucose levels. And the hormones produced in these pancreatic islets are secreted directly into the bloodstream. So remember, we said it's going to be an endocrine function because it's ductless, okay? So the human pancreas actually has about 1 to 2 million islets of Langerhans, and they're all organized around small capillaries into which these cells secrete their hormones. So there are actually 3 major types of cells in the islets. So you have alpha, beta, and delta. And then there are 2 other types of cells as well, gamma and epsilon. So the pancreas, in addition to the digestive functions, actually also secretes 2 important hormones, right? We mentioned insulin and glucagon in order to maintain the homeostasis of glucose. And it also secretes some other hormones, so somatostatin, pancreatic polypeptide, amylin, and these are things that we'll all go over throughout our lecture today. So let's start with the function of beta cells. Okay, so we're going to move to the next slide. So beta cells are actually going to be sensing the uptake of, are going to be sensing the glucose in the bloodstream, right? So this is, again, another reference from the last lecture that we had, showing that, once we have the carb metabolism occur, where we have the complex carbs broken out into simple carbs, they're then taken up into the bloodstream, and then they reach the pancreas. And then in the pancreas, the islets of Langerhans see a lot of that vascular flow from the splenic artery. And then in those islets are actually beta cells. So the beta cells produce insulin and amylin, and that makes up about 65 to 80% of total islet cells. Okay, so we can go to the next slide. So after eating a meal, glucose levels rise in the blood. Okay, so glucose, like we mentioned in the last lecture, needs to be very tightly regulated. And beta cells in the pancreas, like I mentioned, are going to sense the increase in the blood glucose, and they're going to release a hormone called insulin into the blood. And insulin is going to send a signal to the body cells to remove the glucose from the blood by transporting it either inside the cells to be stored, or it's going to be used as fuel. So how do the pancreatic beta cells sense the glucose in the bloodstream and then release insulin? So like I said, the pancreas is seeing a lot of blood supply from the splenic artery. And the islets, even though they only make up about 1 to 2% of the pancreas, they see up to 20% of the pancreatic blood supply. And so we see that the pancreas sees a lot of vascular supply. So how do they sense the glucose? They sense it through glucose transporters, right? So we remember that we had gone over different types of glucose transporters. So there are 2 types. There's sodium dependent, called SGLT, and then there's sodium independent, right, called GLUT, glutes. So like I mentioned last time, there are about 14 different types of glutes, and we had gone over 5 main ones, which are listed here. So GLUT2 is the glucose transporter on the pancreatic beta cell. And so we can go to the next slide. So here we have glucose that's going to enter our pancreatic beta cell. And what happens from there? Glycolysis. Okay, so glycolysis, if we break down the word, glyco and lysis, so it's actually derived from Greek. Glykos is sweet and lysis is splitting. So easy way to remember it, it's actually a breakdown of glucose, which is a 6-carbon molecule. And without going into too much detail, the main point is that, in essence, there can be 2 different types of breakdown, aerobic or anaerobic, depending on the presence of oxygen. And that 6-carbon molecule is then broken down into different things, depending on whether there's oxygen or not. So if there's oxygen, it'll be broken down into pyruvic acid, 2 molecules of that. And if there isn't oxygen, then it's going to be broken down into lactate under anaerobic conditions. So that's the first step. So glucose metabolism is actually initiated once you have phosphorylation of glucose. So that's one very, very key step. And it's a reaction that is catalyzed by an enzyme called glucokinase. The other name for glucokinase is hexokinase 4. So it comes from this family of enzymes called hexokinase, and this is specifically hexokinase 4, or otherwise known as glucokinase. So glucose is phosphorylated by glucokinase to form glucose 6-phosphate. And this hexokinase is a key glycolic enzyme because it's actually going to really have this regulatory step that is irreversible, because these enzymes are going to break down, remember our currency molecule ATP? It's going to break down ATP into ADP. So it goes from a triphosphate to a diphosphate, and it adds that 1 phosphate onto glucose to make glucose 6-phosphate. So this enzyme, glucokinase, is very special than the other hexokinases in the family. And there's a couple of reasons for that. And I'm going to go through a few of those just to tell you why it's so important here. So one of the...
Priya,
Yes.
sorry, please complete your thought and then I have a question.
Sure. So I was just going to say, one of the main differences with this glucokinase compared to the other ones in the family is, of course, it's coded by a different gene, but it actually has different kinetic properties. So I will take the question first, and then I'll go into the differences in the kinetic properties.
Okay, perfect. So thank you very much. The question is, this glucose transporter here for a beta cell, does this need itself for the insulin to be present to open up and allow the glucose to go in the cell, or it does not need it?
So you're talking about GLUT2?
2, correct.
If it actually needs insulin to open up?
Does it need insulin? So normally glucose transporters, insulin goes and works with them and they open up and they allow the glucose to go in. Does this pancreatic beta cell, the glucose transporters here, do they also need insulin, or they are always functioning for glucose without insulin?
So this GLUT2 is actually going to be dependent on the amount of glucose in the bloodstream and how much it's uptaking. So here we're getting into the kinetic property. So that's actually a great question that's leading into this. So what you actually need to know is that glucokinase is going to, like I said, is going to be monitoring that very regulatory step. And I'll tell you why it's important for GLUT2 as well. So glucokinase actually has a lower affinity for glucose. So the lower affinity for glucose actually allows you to adjust for the physiological conditions of glucose that we're seeing in the bloodstream. So what do I mean? I mean that it operates when serum glucose levels are high. Okay, so it's when it sees a high amount of glucose in the bloodstream, that's really when it's operating. Other tissues that use glucose can use them at a lower serum glucose level because maybe they have a higher affinity for the glucose. But here, it's because it has a lower affinity, we need a higher amount of glucose, and that's really what it's dependent on.
Beautiful. Thank you very much for this. I always get fascinated by this transporter because this behaves differently from the other transporters. So thank you.
Yes. So in other cells, like you were saying, the affinity is much less. So, it can uptake at a lower level. So this one's really special. The other way, this actually, this enzyme, this cell, this whole process here in this cell is really special, is that glucose 6-phosphate actually in other cells would inhibit, the enzyme by product inhibition. So the more product you have, it's going to slow down the process, right? But here, if the cell isn't, using up the glucose 6-phosphate, it's not inhibited. So that's another way that this cell is actually different. So
Very interesting.
yes, very interesting. So it actually, we have the same enzyme actually acting in the liver as well. And that's why, it allows it to remain open when it's trying to store as much glucose in the presence of high glucose levels. So you can kind of have the glucose stored as glycogen. So it doesn't get inhibited. So that's another reason that this cell is special. And the enzyme is special as well. So in beta glucose metabolism, glucokinase is really serving as a glucose sensor, right? We kind of alluded to that in past lectures as well. And by recognizing glucose, it's actually initiating glucose-induced insulin secretion. That's what we call it, okay? So it's actually, like I said, very dependent on the amount of glucose that's present. So when blood glucose increases during the postprandial phase, so what do I mean by that? I mean, after eating, when your blood glucose levels go up, glucokinase is usually the dominant enzyme that's really phosphorylating the glucose. Because like I said, other high affinity enzymes from the family, the isoenzymes, usually get inhibited by the product, but this one doesn't. So the regulation of glucokinase activity is actually very important for the rate of glycolysis post-eating. So what we call that in fancy terms is really a flux rate, a glycotic flux rate during the postprandial state. So this is a really complex concept. Okay, so the bottom line is that glucokinase plays an important role in secreting insulin with the ability to change depending on the amount of physiological blood glucose that we have. Another important thing is that the beta cells in the pancreatic islets, which contain glucokinase instead of the other hexokinases, it actually prevents inappropriate secretion of insulin, which would lead to a persistent hypoglycemia. So like I said, because it has a low affinity, and since elevated glucose 6-phosphate kind of serves as an insulin release signal, this is a rate limiting step. So insulin is only released when blood glucose levels are rising above the normal fasting levels. So, Dr. Bean and I tend to have a liking for these pathways, cool beans, right? We love these pathways. We love the enzymes. However, with these pathways, I think we tend to always remember, and I want you also to remember, to think about where we can have changes and how these changes can lead to changes in function, right? So looking at this pathway briefly, let's say there was a loss of function in the glucokinase. That would actually impair the insulin secretion, right? So there have actually been studies where they have kind of done a knockout of the glucokinase. So imagine if the glucokinase wasn't functioning. So in mice, they found that this actually produced hyperglycemia or high glucose levels, which can eventually be fatal, right? There are also mutations that can happen in this area, which lead to certain types of diabetes. So one type of diabetes that can occur is maturity onset diabetes of the young, or MODY. We'll see that later in different lectures. And you can also have neonatal diabetes when it comes to, having mutations in this pathway. So now you can see that there can be more than just two types of diabetes, right? That we hear about, which is typically type 1 and type 2. But there are other, mutations that can happen that can lead to other types of diabetes, or reasons for you to have high glucose, right? And we talked about that being kind of the core of different types of diabetes mellitus. And we're going to talk more about these in future lectures as well. So we can actually see here, going further down, that we're going to have, after glycolysis, we're going to have the citric acid cycle, and we're going to have oxidative phosphorylation, which is going to lead to the production of ATP. So we can go to the next slide. So remember, ATP is the currency, right, of the cell. So we're going to see that glucose will eventually be, converted to glucose 6 phosphate using ATP, and it's going to go through glycolysis, go through CAC, go through oxidative phosphorylation, and then it's going to produce ATP. So we can even go further to the next slide. So that will show you the whole process. And then the level of ATP in the cell is usually proportional to the amount of glucose in the cell, okay, which is proportional to the amount of glucose in the blood. So low glucose in the blood will lead to low ATP in the cell. So here, you'll see that there is an ATP-gated potassium channel, okay? And that's another protein in the cell in the cell membrane. So now ATP actually can have an inhibitory effect on this potassium channel. So let's see what happens to this potassium channel in two different scenarios, okay? So let's say that there is a case of lower blood glucose. So now there's low ATP in the beta cell. So the potassium channel is actually not inhibited. So potassium will continue to leave the cell membrane, or what we call efflux. So this potassium is a positive ion, right? It's going to continue to leave the cell, and the cell's membrane potential is going to become more and more negative, and we're going to call this hyperpolarization. And it's going to lead to inactivation of channels that are voltage dependent, like the calcium channel we see here. And we will have decreased calcium entering the cell. So this is important because the influx of calcium is going to trigger insulin secretion, right? So lower calcium entering the cells leads to lower amounts of insulin secreted, okay? And that happens in a graded response. So now let's say we have a carb-rich meal, okay? Lots of glucose in the bloodstream, lots of glucose enters the cell. Now it goes through the pathway. Glucokinase isn't inhibited by feedback inhibition. So we have more ATP in the cell, more ATP builds up. It inhibits that potassium channel. Now we have decreased potassium efflux from the cells. Okay, so that's going to lead to depolarization, or the movement of the cell membrane potential back towards positive values. So now depolarization is going to activate the voltage-gated calcium channel. So calcium is going to have an increased influx into the cell, and that's going to trigger insulin secretion through these granules that are loaded with insulin, which is then going to be secreted into the blood. And then remember, again, these responses are graded, okay? So now that was all about insulin. Okay, so now we can go to the next slide.
So I feel so proud that I'm able to follow your talk and kind of do this mousy thing everywhere. So I am a great co-presenter with you. So thank you very much.
Thank you,
All right.
Dr. B.
You are very welcome.
So here, oh, we skipped the slide. So I'm sorry, I forgot that I had the slide in there. So this is just showing you, the process with CAC and, the oxidation, which is going to lead to the ATP production, okay? So this is the step that we talked about before, the ATP interacts with the potassium ATP channels and then the calcium influx. We can go to the next slide. Okay, and this is just an overview of the whole pathway again. And here we are. So I talked to you all about insulin, and now I'm going to tell you a little bit about the other hormone, amylin, right? So I didn't quite forget. And I want to remind you also, so beta cells produce insulin. They also produce amylin, okay? So amylin actually, it slows down gastric emptying. And it also prevents spikes in blood glucose, okay? And it's secreted along with insulin from the pancreatic beta cells. And so it could be deficient in people who are diabetic as well. And there's actually, another drug, which we'll talk about in later lectures as well when we go through diabetes medications, called amylin analogs, okay? So an example of that is pramlintide, and that's going to inhibit glucagon secretion. It's going to delay gastric emptying, and it's going to really cause you to feel satiated. So that means that, it's good for patients who have high blood sugars post their meals and who maybe, want the additional benefit of losing weight. So it can help with weight loss, and it won't cause any low sugars by itself. So that's where we can see this pathway playing in.
Very interesting. So amylin's job, although it is being secreted with insulin, its job is to actually reduce the gastric emptying. And then the outcome of that will be, so if let's say I have eaten sufficient and there is insulin being released because I have carbohydrates and glucose in my blood, glucose, why would further gastric emptying be slowed down? What's the
So
purpose of
we're actually going to get to this. So the pancreas is very special in where it has different types of signaling called paracrine and autocrine signaling. And we're going to see all of the hormones that are released are actually going to have different regulatory effects on each other to maintain a tight balance.
Got
So
it.
that is the very simple answer, but we're going to see exactly how alpha cells, beta cells, they all talk to each other in order to kind of maintain checks and balances.
Got it. It is so interesting that we have such an intricate system. Even then, this system continues to become failed and failed and failed. And after
Yes.
50, we develop diabetes. It will be fascinating to reach that point of pathology as well. So, sorry, should I go to the next slide or?
Yeah, actually, yep. So we can actually talk about it right now. So that was a great lead into this segment. So basically, with such important hormones being secreted, like you were saying, Dr. Bean, you would imagine that there's so many regulatory, factors in the system, and there are. So the feedback system in pancreatic islets is called paracrine signaling. And that's what I was mentioning. Paracrine signaling is actually when a factor that's secreted by a cell affects other cells in the local environment. So in the pancreas, it can be based off of activation and inhibition of the islet cells by endocrine hormones that are actually produced in the islet, right? So insulin actually can inhibit alpha cells, and glucagon can actually activate beta and delta cells. And somatostatin can actually inhibit alpha and beta cells. So there's paracrine signaling, but there's also a different type of signaling called autocrine signaling, and it has the word auto in there. So what I'm talking about is when a cell secretes a messenger molecule that binds to the receptors on the same cell or the same type of cell, right? And we can see this often with beta cell to beta cell communication in the pancreas. So there's basically two types of signaling in the pancreas where hormones basically keep each other in check and balance. So autocrine and paracrine signaling, very complex. I will mention a few important players, especially with insulin. So there are some major stimulants of insulin. We saw glucose already. There's amino acids that can play into that. So leucine. There's incretins, which are other hormones. So GIP and CCK. There's different drugs, right? Like sulfonylureas, which will actually, through actually the potassium ATP channels can again cause stimulation of insulin release. And there are also other little, amplifiers or potentiators, which can be nutrients or neurotransmitters, fatty acids, amino acids, which can kind of play into insulin secretion. So, for example, there's one fascinating thing where often there's something called a cephalic phase of release, which is by the vagus nerve. So when you're, let's say, sitting down for your meal and you see your plate of food and you smell your plate of food, before you even taste it, eat it, and before the whole process starts, which we talked about with the breakdown, there are little neurotransmitters being released like acetylcholine or gastrin, which basically help prepare the body and say, hey, the sugar's coming. So get prepared, So these are little things that happen, small mechanisms before we even get to the major triggers. And it's absolutely fascinating. So these mechanisms actually prepare your body and say, hey, there's going to be an increase in the plasma glucose and we want to prevent it from rising too much after a meal. So let's get ready for this. And then you also have these major inhibitors, right? So you have somatostatin, you have epinephrine, and you have other drugs like HIV protease inhibitors. So that's, a couple of the checks and balances that we can have with something major like insulin. So that was a bit about the beta cells, insulin, amylin. So now we'll talk about the function of alpha cells. So we can go to the next slide. So we're going to talk about the alpha cells, and alpha cells are really making up about 25% of the islet cells, and they secrete glucagon. So glucagon, we had briefly mentioned before, it basically has the opposite effect of insulin. So it's antagonistic to insulin. So glucagon increases blood glucose levels. So how does that happen? Well, glucagon actually stimulates gluconeogenesis and also glycogenolysis. So liver cells have glucagon receptors. And when glucagon binds to the liver, it converts the glycogen into individual glucose molecules and then releases it into the bloodstream. And this is known as glycogenolysis. So glycogen and lysis, breaking down of glycogen. And then as these stores kind of become depleted, the body is thinking, well, how can I increase the sugars? And that's where, glucagon then kind of tells the liver and kidney, hey, let's make more glucose, right? So then it goes into a process called gluconeogenesis. So new glucose, and then genesis, the process, the production of it, right? So that's another way of actually increasing your glucose in the bloodstream through glucagon.
That is fascinating. So if I just took my meal, there is a bunch of carbohydrates, let's say, in it, and then there is glucose that goes into the body. So insulin is secreted to say, man, take care of this glucose and push it into the cells. Let's say 2-3 hours later, now I do not have enough glucose in the body, and I need to keep a certain level. It is the glucagon's job to come into play and say,
yes,
body needs some glucose. This guy is not eating more. I need to go produce it. Correct?
Exactly. So intermittently, you can imagine between meals, slowly that sugar level will come down. And when it comes down to a low enough level, glucagon's going to be triggered and say, okay, it's time to maintain these levels in a good target range. So it's going to have the opposite effect, and it's going to drive up the levels.
Very interesting. Thank you very much.
Of course. So I also mentioned that there were other types of cells in the islet. So there are delta cells, which is going to be about 3 to 10% of the total islets, and they're going to secrete somatostatin. And somatostatin actually inhibits the secretion of insulin and glucagon. It also suppresses, a lot of the exocrine secretions of the pancreas. So we'll see that it'll inhibit CCK, which is going to stimulate the enzyme secretion, which we talked about. It's going to inhibit things like secretin, which is going to, which usually stimulates the bicarb secretion. So it's going to inhibit that as well. And, so again, we're seeing a lot of cell-to-cell communication amongst the cell types in the islets of Langerhans, and they all control secretion of some hormones by the other hormones. Interestingly, somatostatin also inhibits growth hormone from the pituitary gland. So the pituitary gland, remember we talked about in the prior lecture, sits at the base of the brain, secretes a lot of hormones. So it actually inhibits growth hormone from there as well. And we'll see that, somatostatin can be used in different disorders like acromegaly, because it actually inhibits the growth hormone secretion. And it can even be used in other things like VIPomas, where you might have overproduction of hormones like VIP. So that's another place where somatostatin can kind of be used. The other cell that we see is a gamma cell. So gamma cells actually produce pancreatic polypeptide, and that makes up about 3 to 5% of the total islet cells. So we can actually go to the next slide.
And I want to just make a quick interjection. My apologies.
No, of course.
These mechanisms and their discussions, for example, you just discussed that how body not only does not allow the glucose levels to go too high in normal healthy individuals, it also does not let it fall too low as well. So it maintains a specific level. And these stories, the mechanisms, these are so fascinating. If somebody was just teaching and talking about these stories about medicine, I could just sit and listen to those the whole day. So thank you very much for telling these stories.
No,
normally it is me who's telling it, but thank you. It's fascinating to listen.
Yes, absolutely. So as endocrinologists, as people training in endocrine, we absolutely love our pathways. And, it's fascinating to go and see, go back to your pathophysiology, go back to the biochem and really see where, how the normal body functions. And then when you alter these mechanisms, what happens, right? So it's really important to see how we have the checks and balances in the body. Okay. And we can go to the next slide. This was a pretty good overview of some of the things I mentioned. So now we were talking about the gamma cells, I believe I was telling you about. So gamma cells, like I said, they produce pancreatic polypeptide, and they make up about 3 to 5% of total islet cells. So actually, a lot of the function of pancreatic polypeptide is unknown. Actually, despite so many years of studies in medicine, there's a lot of things we still don't know. So it's actually a lot of it's unknown, but we do know it has a role in the endocrine and exocrine pancreatic secretions. But a lot of it is still to be figured out. And then we have the epsilon cells. So that actually produces ghrelin, and the epsilon cells make up about less than 1% of the total islets. And ghrelin, you've probably heard, is a hormone that stimulates hunger. So we'll keep it basic. We'll leave it at that. But I think this table is really nice. It tells you the cells and it tells you the hormones. So I thought it was a good, quick summary of the islets.
Absolutely.
So yes, so these five, are really the five cells of the islets, and like I said, the three major ones are alpha, beta, delta, and then you have epsilon and gamma as well. So we're having a lot of educational talk today, which I think is fascinating, and we're going to get into some of how this, pathophys can kind of apply to diabetes as well, and measuring insulin and some of the phenomena that can happen. So let's go to the next slide, and we'll take a deep dive into insulin specifically. So we're going to look at insulin structure and the function. Okay, so insulin is actually a pretty small protein, and it's composed of 2 amino acid chains that are linked to each other by disulfide linkages. Okay, and when the 2 amino acid chains are split apart, insulin kind of loses its functional activity. So how is insulin made? This is actually really interesting. So insulin is actually synthesized in the beta cell by like the usual machinery that's used for all of protein synthesis. So it begins with the translation of the insulin RNA by ribosomes that's usually, in the endoplasmic reticulum, and it forms this protein called pre-proinsulin. Okay, so it's pre-proinsulin, which is then cleaved in the endoplasmic reticulum to form proinsulin. And that's consisting of 3 chains of peptides, A, B, and C. And then, most of the proinsulin is further cleaved in a place called the Golgi apparatus to form insulin. And that's composed, like I said, of the A and B chains that's connected by disulfide linkages. And then there's the C chain peptide that's called the connecting peptide, or what we hear often in the clinical world as Cpeptide. Okay, so now we know exactly where this is coming from. So the insulin and the Cpeptide are packaged into secretory granules and then secreted. Okay, so, and there's one interesting thing, about 5 to 10% usually of this final secreted product in the granule may have some form of proinsulin still. Okay, so now let's apply some of this into the real clinical realm. Okay, real clinical world. So why do endocrinologists value C-peptide so much, and what does it tell you? Okay, so measurement of C-peptide on immunoassay, okay, so on blood work, can usually tell you how much natural insulin someone is actually producing. Okay, so we saw that C-peptide was kind of integral in this whole pathway of insulin production. And people with type 1 diabetes who are unable to produce insulin will have lower levels of C-peptide. And now we see why. So endogenous insulin actually refers to the insulin that the pancreas makes. And then you have insulin that you can inject, right? That we often have type 1 diabetics on. A lot of type 2 diabetics are also on insulin. That's called exogenous insulin. So it's either insulin that you're injecting or infusing by an insulin pump, right?
So let me back up for a second. So you're saying, imagine you take my blood, and let's say I take insulin from exogenous route as well, and I produce some insulin as well, just making up a situation. And let's say you take my blood, and now you see that there are 10, I'm making up numbers, 10 molecules of insulin, and there are 10 molecules of, let's say, C-peptide. That means that 10 molecules are actually internally produced because they are coming from the same one peptide structure. And then in addition to that, there are 20 molecules of insulin without any C-peptide.
Yes.
And now you can tell how much Mubin is injecting insulin versus how much he's producing insulin, correct?
Yes. And the interesting thing is, So what you said is absolutely correct, right? So the endogenous insulin and the C-peptide is going to be reflective of the endogenous insulin and not the exogenous insulin. So that's why, C-peptide is really, really important. It's a better indicator of your beta cell function, right?
So
And
there's
the
a
other thing,
question, sorry, Priya. There's a
sure.
question about T half. So Erica Cat is saying,
Yes.
what does the T half mean?
Right. Great question, Erica Cat. So that is referring to the half-life. And that's something else that I was going to get to. So why is C-peptide actually a better marker? Well, insulin's half-life is only about 6 minutes, right? C-peptide actually has a longer half-life and it lasts for about 35 minutes. So when someone actually administers insulin exogenously, it's going to circulate through the peripheral tissue before it reaches the liver. Endogenous insulin secretion, so insulin that you're making in your body, actually initially, will go to the liver and it'll be taken up, and about 50% might reach the peripheral tissue. But C-peptide has a longer half-life. It's going to last longer in the system. And so if you measure that, it's going to give you a better indicator of what's actually going on. It has less metabolism in the liver. It's removed by the kidneys and the circulation, and then it's degraded. So that's a very, very good point, Erica Cat. That's actually another thing I was going to talk about, but you cool beans are so smart and always one step ahead. So you got to it before I did.
Two more questions.
Sure.
Uh, Elk Apt Root says CCK equals cholecystokinin, correct?
Yes, exactly.
And the next question, Kelly says, can the body become better or worse with practice like intermittent fasting at regulating glucose levels through the glucagon method?
Okay, loaded question, Kelly.
Loaded question, huh?
Loaded question. So intermittent fasting, there's a lot of buzz around that right now. And one interesting thing is when we talk about intermittent fasting, when we talk about the studies, there are different types of intermittent fasting too, and that also needs to be gleaned upon in the studies. Are we talking about time restriction? Are we talking about intermittent fasting where one day you are fasting, one day you are allowed to eat anything you want? So there are actually different types of intermittent fasting also. So that'll also be dependent on answering your question. There are some things, which show that intermittent fasting can be beneficial. Some studies show that you still need a caloric deficit, but we can definitely talk about it in more detail, maybe in one of the future lectures. I know, Dr. Bean, we were
Absolutely.
talking about maybe doing one on, intermittent fasting or different diets and how this kind of plays in. And I would love to, glean into the literature a little bit more, review it from at least, a medical education standpoint, what we know from scientific literature. And again, it wouldn't be medical advice, but just to see, what the literature says out there about intermittent fasting right now and how it relates to these pathways.
Got it. And I see a question from Nick Ariza. He himself is a doctor,
Yes.
retired, and he is talking about, are you aware of Dr. Neil Bernard's work? So maybe we'll do someday, you and I, Priya,
Yes.
we'll look at Dr. Bernard's work and maybe discuss that here as well. Nick, thank you very much for the suggestion.
Yes. Thank you so much, Dr. Nakriza. All right. So we talked a little bit about exogenous, endogenous insulin, and then in people who are potentially injecting insulin, we can look at uh, how, for example, we were talking about if someone gives themselves exogenous insulin, their insulin levels might be raised, but maybe the C-peptide level will be normal because C-peptide is not found in commercial preps of insulin, right? It's something that our body produces. So that's one thing we were talking about. And then another good thing about measuring C-peptide is you don't have this cross reactivity, which you can have with insulin. So our body sometimes can make antibodies to insulin, and that could interfere with measuring insulin. And then, we talked about the half-life, which is brought up by one of the cool beans. So we've kind of covered that. And one other thing I will mention is, so just quick couple of different scenarios where you can actually have higher levels of C-peptide. So one is, for example, if you have a something called an insulinoma. So a tumor that's really secreting a lot of insulin. You have a lot of insulin production going on, you're going to have more C-peptide. So that's one way. Another way is, when I mentioned that there are drugs like sulfonylureas, which treat diabetes, which actually stimulate the release of endogenous insulin, right? Which I said comes through, again, the potassium ATP channels and goes through the whole process, which we talked about. You're going to have more release of endogenous insulin, which means more C-peptide. You can even have, differences in the metabolism, right? So if you have problems in the kidney or the liver that affect the metabolism, you might have raised levels. You can also have lower levels, right, of C-peptide, like we talked about with type 1 diabetes. Or let's say you have removal of the pancreas because of surgery, or you have, I guess, some sort of damage to the pancreas. That might be able to, cause lower levels of C-peptide that way. All right. So those are some instances where you can have higher levels of C-peptide, and then you can have lower levels of C-peptide. So, and then if we go to the next slide, so this is another fascinating slide, because it shows you all of the different functions of insulin on the peripheral tissue. And you can see how many different tissues this one hormone affects in how many different ways. Okay, so when insulin is secreted into the blood, it circulates, throughout. And like I said, the half-life is pretty short, about 6 minutes, and it's pretty much cleared away within 10 to 15 minutes or so. And, portion of the insulin combines with receptors on these target cells, and the remainder is actually degraded by an enzyme called insulinase, mainly in the liver and then to some extent in the kidney as well. So there's pretty much this like rapid removal of insulin. And we want that, right? Because we want, again, tight control. So let's talk some more about the function on each of these peripheral tissues. The main ones we'll talk about probably will be the muscles, the adipose tissue, and the liver, right? And we know that insulin is causing rapid uptake, it's causing storage, it's causing use of glucose by almost all tissues of the body, but especially in the muscles, the adipose tissue, and the liver. So we can take a look at muscle. So, excuse me. So in muscle, insulin is going to promote muscle glucose uptake and metabolism. So the muscles are going to use a large amount of glucose. When do they use a large amount of glucose? Well, one is during moderate or heavy exercise, right? When we're exercising. So the usage of glucose, this specific usage, right, doesn't require large amounts of insulin, because exercising muscle fibers actually make, the cell more permeable to glucose, even in the absence of insulin, because of the contraction process itself. And we alluded to this a little bit during the last lecture. And then the other time you have, a large amount of glucose is like few hours after a meal, right? At this time, the glucose concentrations are pretty high, and the pancreas is secreting large amounts of insulin. And the extra insulin causes this rapid transport of glucose into the muscle cells. And then the other effect that we have is the storage of glycogen in the muscle. So if the muscles are not exercising after a meal and the glucose is transported into the muscle cells, because there's an abundance, then most of the glucose is going to get stored in a form that we mentioned, which is glycogen, right? So that can be up to 2 to 3%. And then the glycogen can be used later for energy by the muscle. So that's pretty much the muscle. And then we have the liver, right? So insulin promotes liver uptake, storage, and use of glucose. So one of the most important effects of insulin is to cause most of the glucose absorbed after a meal to be stored almost immediately in the form of glycogen in the liver, right? And then in between meals, when the food is not available and the blood glucose concentration begins to fall, insulin, the secretion will decrease rapidly. And the liver glycogen will be split back into glucose. Remember, we mentioned that. And then it's going to be released back into the bloodstream to keep the glucose concentrations from falling too low. So insulin actually affects many enzymes also. So for example, here we go again with some pathways. So just some brief mention so we kind of understand how to what degree, to what extent, insulin is really acting on everything. So insulin can actually inactivate and activate enzymes, and different enzyme activity. So for example, it can inactivate liver phosphorylase, right? And this is going to inhibit glycogen splitting into glucose. It can increase the activity of enzymes like the glucokinase and kind of cause the initial phosphorylation of glucose and trap it into a cell, because glucose 6-phosphate will be trapped in that cell. And then it can activate enzymes that are going to promote glycogen synthesis. So basically the net effect here is that you have an increase in the amount of glycogen in the liver, and the glycogen in the liver can actually be almost equivalent to like 100 grams in the whole liver. And the other net effect is that you want to inhibit gluconeogenesis. So it's going to do this mainly by decreasing quantities and activities of liver enzymes that are required for gluconeogenesis. So that'll, decrease that decrease in activity will kind of stop that pathway.
Got it.
So those are two net effects. And then, I guess the other thing also, which is very interesting, is that insulin can tend to decrease the release of amino acids from muscle. And then in turn, that will affect gluconeogenesis too, because a lot of that is used in gluconeogenesis as a precursor. So that is also there. And, as insulin kind of increases, the utilization of glucose by most of the body's tissues, it kind of automatically decreases the utilization of fat. So it kind of spares fat. And then the excess carbs, I guess, that can't be stored as glycogen are often, converted under stimulation by insulin into fats and then stored in the adipose tissue.
So is this the, sorry for the interjection. So is this the thing that makes us gain weight if we are eating? Or there are other factors for the weight gain as well?
So insulin will promote the conversion of most excess glucose into fatty acids. And then the fatty acids are then packaged into triglycerides in VLDL. So very low density lipoproteins. And then that gets transported into the blood and then to adipose tissue, and then it gets deposited as fat. So that's one way that happens.
Got it. Thank you.
Yes,
and of course, for the cool beans here,
yeah,
weight gain can be of many types.
yes.
For example, somebody just retaining water would make them gain weight as well. So when I said weight gain, that was more in terms of glucose and converting that for fat tissue and storing it into the fat.
Yes. And even you'll see, there are other enzymes that can even be inhibited, right? So you can have inhibition of enzymes like lipases, right? That might, so you won't have as much release, of the fatty acids from the adipose tissue. So that'll be inhibited as well. So that's one more way. And then there's also proteins that can be affected, right? So in the case of proteins, insulin tends to have a more direct effect in promoting, uptake of the amino acids and then conversion into protein. And then it inhibits the breakdown of proteins that are already in the cells. So it kind of affects every single system, right? Whether it's the proteins, the fats, the liver, the muscle. So it kind of covers it all. And so how does insulin really enter these peripheral organs? So that's another question, right? So let's take a look. So we've gone through so much today. It's been a loaded lecture, but we're going to cover one last pathway as well. So, to initiate its effects on all of these target cells that we talked about. So insulin first has to bind, right? And it has to activate this membrane receptor protein that's sitting there. And then this
we're going to talk about the doorbell and the door. We're going to talk about the insulin being the doorbell, and then the glucose transporter as the door to allow the glucose to get in.
That's a
correct?
great way to think about it. So, I mean, if you're looking at the insulin receptor, it has four subunits, right? So it's held together by these disulfide linkages, and it has two alpha subunits, which are kind of outside the cell membrane, and then it has two beta subunits within, that are sitting within the cell membrane. So insulin will kind of come, it'll bind to the alpha subunit of the receptor, I guess, ring the doorbell, and kind of autophosphorylate the beta subunit receptor, and it'll open up the doors and it'll kind of induce this tyrosine kinase activity. So this is an example of an enzyme linked receptor. Okay, so you have this tyrosine kinase activation, which is going to lead to phosphorylation of so many different intracellular enzymes. Okay, and they're called insulin receptor substrates. So they're going to be a bunch of insulin receptors that are going to get activated. Some enzymes are going to get inactivated. And, remember all the enzymes that I was mentioning along the way previously that acted in different areas of the muscle or, the liver. So these are how, this is exactly how, insulin comes, rings the doorbell and says, I'm coming through. We're about to make some changes. So this is exactly how it happens. And these receptors that, kind of change the tyrosine kinase activity, cause these cascades. And as you notice, phosphorylation has been such a key thing, right? And it honestly turns on and off different activities of enzymes. So it can increase or decrease different things. And all of these tend to mediate and have different effects, like I said, on glucose, on fat, on protein metabolism. So
This is
it's really,
fascinating.
yes.
So
So,
can I, my apologies. So
no, of
insulin
course.
comes outside the door, outside the home, presses
Yes,
the doorbell, which causes something inside the home to go chime, and then that causes some people, some enzymes to become active, and they are saying, okay, we're going to go do something. There is somebody at the door asking us to do something. That is the mechanism here.
exactly. So
Wow.
literally within seconds of insulin, binding, the membrane is having so many changes, and it's allowing, either uptake of glucose or there's some sort of translocation with intracellular vesicles. And if you remember, we had even talked about, the vesicles like GLUT4 that were affected. So that's, this is really what's coming into play here. And we're having a lot, you can have a lot of changes in the cell membrane. It can be permeable to a lot more amino acids or ions like phosphate and potassium. And there's can be a lot of increased transport of things into the cell. There can be changes in enzymes through phosphorylation. So it really triggers this cascade. And it has, so many effects, whether it's even on things like messenger RNA and changing the rates of translation, which is a slower effect. The effects that we're talking about here with these cascades of phosphorylation, membrane changes are very quick. But, things where it affects really translation of mRNA into new proteins, that's a little bit slower. And then you also have it affecting, transcription, which is even slower. So insulin, basically, if you think about it, it really to achieve metabolic goals, it has so many different effects on enzyme machinery, right?
Absolutely. This is fascinating.
Yes, absolutely. So here we've come across a whole pathway, really talking about from beginning to end. We've spoken about how we had, the pancreas involvement, its exocrine and endocrine functions, how we have insulin and glucagon and somatostatin and pancreatic polypeptide and amylin, all of these hormones that interact with each other through paracrine and autocrine signaling. Um, we
Sorry.
had, yeah, and then we had the exocrine function as well, which we had seen in previous lectures that was tied in. And then we see exactly how, insulin is taken up by the peripheral tissues and the important effects that it had on the liver, on the muscle, on fat, on protein. And, what I think is also fascinating is, all of these cascades and different enzyme changes and triggers that we see with either, inhibition or, activation of different enzymes and the regulations that occur at these biochemical levels. And interestingly enough, now we know a lot about beta cells. I feel like through this lecture, we learned a lot about the beta cell function, the structure, how that all connects. And the same with insulin, right? We talked about the actual structure and function of the insulin, the difference between endogenous and exogenous insulin. So I think we've covered a good scope here. There's
This
actually,
is a huge gold mine to
yes.
understand glucose, how the pancreas is helping keeping a balance of glucose, then how is that glucose entering the cell, what is the role of insulin, the exogenously produced insulin and endogenous. This is a beautiful talk. Thank you for
Yes,
doing this.
of course. And there's even a real life tie-in that's come out just recently, actually. So just for the cool beans, since I know they love to keep up to date, I recently came across a paper actually that's by Tang et al. Called SARS-CoV-2 induces beta cell transdifferentiation. So
Hmm.
this is actually, quite timely for our lecture that we've done. And again, this is just medical education. It's not any clinical advice that I'm giving here. But, this paper was very interesting because we know that, there's such a close interaction between COVID and diabetes. And we know that individuals with diabetes, tend to be more symptomatic. They have higher risk of complications, higher death rates. And I was even reading that amongst all the deaths in the United States, the chief medical officer in the ADA actually said 40% of deaths from COVID in the United States are among diabetics. And like I said, even clinically, we've noticed that a lot of patients who were diagnosed with COVID ended up having new onset diabetes. And so this paper talks about how there might be transdifferentiation of beta cells. And what do I mean by transdifferentiation? I mean when there is a process from one cell type changing into a different cell type morphology. So we talked about alpha and beta cells, right? So in this paper, they actually talk about how it's possible through the studies that they've done on COVID-19 autopsy samples or sequencing that they've done. So they've done some RNA sequencing on SARS-CoV-2 infected pancreatic islet cells, right? So things that we've talked about in this lecture. And they found in that study that, there might be a shift in the way the pancreatic beta cell is behaving after a COVID infection. So they
Wow.
found that, the pancreatic beta cells particularly can be infected and affected, but that their function might be more similar to gaining certain properties that alpha cells have, like production of glucagon and actually lower production of insulin. So that's something that they saw.
Very interesting. Thank you very much for sharing this. I love it. So for the next topics, number one, let's just see if there are any questions. Number two, for
Sure.
the next topics, would we now start moving more towards pathophysiology and then the maintenance of management of
Yes, of
diabetes?
course. I think, going through the different types of diabetes that we know about, going through the different medications, where they fall in this pathway, how they affect, and how they treat and how better manage diabetes, I think will be very interesting to go into. I think we can have some lectures, as the cool beans have mentioned, they want to see a lot with, diets, I feel like, and intermittent fasting and things like that. So we can definitely incorporate all of those things. But I think we'll start getting into, clinical management, different medications for diabetes as well.
Awesome. Thank you very much. So a few questions. And Roman, I see your comments. I'm trying to figure out how to generate Discord's permanent link. As soon as I can learn, I would share that here. Meanwhile, there is a question from Ali G. He's saying, can you please discuss diabetes insipidus as well?
Of course. So DI is one of the emergencies that we see in the hospital from an endocrinology standpoint. So we can definitely do that as well.
Got it. Svetlana says, A little pen icon in the left corner of PowerPoint allows lecturer to use a laser pointer. It would be
Oh,
easier to
yes,
follow the lecture if it is used. Okay, cool. Thank you very much,
definitely.
Svetlana. I would do that. There must
Dr.
be a
Bean
little.
was my lecture pointer today, so
Yeah,
he did a
today I'm
fantastic job. So
totally
thank
happy
you.
to be that. Um, let's see if there is any more questions.
There's actually, while you're looking for questions, another fascinating thing, the concept of artificial pancreas that often comes up. You
Yeah,
know,
that is a beautiful
yes.
concept.
And we've come so far with insulin pumps and continuous glucose monitors and what we call now with that closed loop type of idea. So I think that would be another fascinating thing to discuss, especially now since we know all of the interactions between alpha and beta cells and insulin and glucagon.
I always think, why haven't we reached a point where
Yes.
we actually don't have to do the exogenous insulin? Why can't we have the cells inside us?
Yeah.
So let's say a baby is born. In the first few years, so this is my project Phoenix, which I think about. In the first years of life or adulthood, that baby donates their own stem cells or their
Hmm.
pancreatic beta cells that go in a freezer. And then when they are older, their cells are replicated, cloned, and then injected back into them and placed somewhere. Why can't that happen?
That's very interesting, actually. Very, very interesting, Dr. Bean.
Yeah.
It's a very,
Why
very
do we
novel
let
thought.
the cells become senescent, become old and die, and then we don't have any more cells, and now we're injecting the new insulins? Why not my cells, when they're healthy, go somewhere, and then when I am older and I need insulin, we replicate, we clone those cells. My own cells are cloned, so they're
Yeah.
compatible with me, and then put back in my body.
That's a very interesting thought, actually, and in multiple different ways, right? When we talk about stem cells, generation of and differentiation of those cells, and using those. So that's very interesting. Very,
So
very
maybe
interesting concept.
we'll do that project. So
Yeah.
Jennifer says, where is your lecture schedule? Post it so we can plan for it. Discord, or if so, can you provide the invite? Normally for the lecture schedules, Jennifer, I'm gonna share my. I'm still trying to figure out the Discord link. I am just so bad with Discord that I have no idea how to use it correctly. I'm gonna quickly show Jennifer where to find the lecture schedule. So if we go to drbean.com / interview schedule, we have very recently started updating it. So if you can see here, Priya's previous lecture was on 30 September, and if you click here you can watch that lecture. Then today, um, yesterday was FLCCC weekly, and then 14 October today at Dr. Priya, and then we'll continue to do this. For example, tomorrow at 9 a.m. Pacific time, we would have Professor Bilkis Shabir tomorrow morning, and so on. So here is the schedule.
Yeah, no, absolutely. I think it's great. It's such a fantastic platform, Dr. Bean. I always wonder if I had access to this while I was, going through medical school or when I was a pre-med, how fascinating this would be and what an encyclopedia of knowledge this is to have, different speakers come and talk about different topics. And even when you're lecturing, it's absolutely fascinating. And even just as a refresher, and I just want to also thank the Cool Beans. I've been getting your messages across Twitter, across Instagram. I've responded to some of them, and I'm sorry if I haven't responded to you yet. I will. But I just want to thank everyone for all the support, all the comments, questions. It's absolutely wonderful, and always grateful to Dr. Bean for letting me come here and lecture. So thank you so much.
Thank you so much. So I'm so sorry I was distracted. I was trying to get
No, of
Discord
course.
link. I could not find it. So let's close the talk. Roman, I would try to figure out where the Discord link is and either tweet it to you or in some other talk, we'll put that out. Uh, Priya, thank you so much for your time and for
Of
being with
course.
us.
Of course. Thank you so much, Dr. Bean. And Cool Beans, I'll
And
see you
thank you
next
for
time.
teaching us, most importantly. Beautiful teaching. Thank you very much.
Thank you.
All right. So, Cool Beans, thank you very much. So, we will not see each other this evening, because we have done this lecture. Tomorrow, also, nothing in the evening, because we'll have a talk in the morning at 9 o'clock Pacific time, and we would have Dr. Professor Bilkis Shabir with us. She is a teacher. She's a head of medical department in Mayo Hospital, where I had done house job. So quite a near and dear to my heart guest. So we will meet her tomorrow at 9 a.m. And once again, Priya, thank you very much for your
Of
information and
course.
your time. Bye bye for now.